So the focus of today's discussion is going to be on developing an Ascii that measures what you want. And I've based this on an article that I shared with you called 12 Tips for Developing an Ascii That Measures What You Want. I'm not going to go through all 12 tips today. I didn't want to, in 45 minutes, rush through all 12 tips. I'm actually just going to go through the first 6, which all speak to developing the Ascii in the first place. And I think we can have a meaningful discussion about those. So just a bit of background. An Oski is an objective structured clinical examination. That's what it stands for. They were first introduced in 1975, and it's sort of become the gold standard for assessing clinical skills. From my point of view, I've been involved in organizing a lot of Oskis. I joined this unit in 2016. We used to have a system where we did a lot of practice Oskis during the year, formative Oskis, and then would have big once-off sort of end-of-year exam Oskis. And we did that 2016, 2017, 2018, 2019. And to give you an indication of what those were like, our last 2 Oskis in 2019, I've got a picture there of the floor plan we used. We ran these Oskis over 7 mirrored simultaneous circuits. We ran them over 4 sessions in a day at about 95 students in a session. We would examine about 380 students in a day. We'd have to bring in and train about 42 examiners, 36 simulated patients. We had 10 coordinators, 10 invigilators. We printed nearly 5,000 rubrics. So it was kind of like organizing the Olympics, and there was this really stressful thing that used to happen at the end of the year, but also a really stressful thing for the students at the end of the year. And then COVID-19 came along, and obviously we had to switch to our emergency remote teaching for a while. We got going with the clinical skills curriculum again. But obviously, we couldn't have Oskis where we get almost 500 people on campus anymore during COVID, which was what we were doing at the end of 2019. So it actually was the motivator we needed to push us into a more programmatic form of assessment. So what we're trying to do now is make sure that we've got an Oski assessment process that both gives us an accurate judgment of the student's competency, but also gives a maximum learning benefit for the student during the process. So it's that whole idea of assessment that's not only of learning, but also for learning. And it's a bit more of a longitudinal assessment of the student's abilities in as many different domains as possible. It allows the students to improve as they learn from each assessment and can do better in the next one, especially with the feedback we give them after each one. And because they're revisiting the work multiple times, rather than cramming it once off, there's some better retention. So instead of having this one big bang Oski at the end of the year, we now run, each student does 3 Oskis that we spread out. We started them in May, and they're ongoing at the moment, where each one's slightly more lower stakes and they can learn from each one. And they can recover from one poor performance or a bad day, and hopefully actually at the end of the day know their skills much better. So we've sort of swapped to a programmatic approach. Each student does 3 lower stakes Oskis, but we run about 35 Oskis a year, so we do have a lot of practice. So anyone that's run an Oski will know this experience. This is from my phone. The last time we ran a couple of Oskis in a day on the 5th of August. Running Oskis might be bad for your heart with regards to stress, but it's great with regards to exercise. So that 9 kilometers I did was just between the 3rd floor and our holding venues in the 5th floor. So Oskis, if nothing else, can be a great exercise plan. And if you've ever run an Oski, you know what it's like to go to sleep at night and hear bells ringing in your ears. But I think despite being hugely resource intensive and hard work, they can be a really meaningful assessment of a student's skills. So this article is really based on developing a valid Oski. And the concept of validity is all about you want assessment that actually measures the construct that it intends or claims to measure. So that's what this article is all about. And they use a very interesting framework on validity, Keynes' framework, which I hadn't come across before. I've obviously heard of validity a lot, and people talk about construct validity and face validity, but I thought this was a nice framework when thinking about developing an Oski. So they talk about 4 particular areas that you need to look at to decide if your Oski is valid or not. So scoring is all about, are you able to accurately translate the student's performance into a score that reflects that performance as best possible? So you've got to make sure that you're getting the student's performance recorded in an accurate score. Generalization speaks to whether the specific examination you do is a reflection on the test performance environment. So in other words, I mean, you can't test everything. So you want to make sure that your Ascii can be generalized to anything that you could possibly have tested. And can you generalize it to the whole curriculum? So is the assessment the students do a reflection on their knowledge over the whole curriculum? Extrapolation speaks to whether their students' performance in the Ascii will translate to actual performance in real clinical practice. So can you extrapolate from the students' performance to what they will do when they actually interact with real patients in the clinical setting? And implications is whether or not you can make accurate decisions based on your Ascii. So how will you be able to interpret the information from your Ascii for decision making? So I'll keep coming back to these in the things that we do to try and make sure that we've got a valid Ascii at the end of the day. Two of the biggest threats to validity. One of them is construct underrepresentation. So that's when you've got too little or inappropriate sampling. So that could be anything from too few test items to having for example, an Oski rubric that where fact recall or trivial content actually lands up outweighing the thing that you actually wanted to test, the construct that you're interested in. So if you've got a station where the student can do well enough from recall to counter the fact that they didn't actually have the motor skill you were interested in. So you've got to make sure that you're measuring all the aspects of the construct of interest that you want to test. And then construct irrelevant variance. This was a new term for me. Is anything unrelated to what you actually want to test that results in score variability. So what you want to make sure is that the only way a student can do well is if they actually perform well in the construct you want to test. And the only reason a student should do badly is if they are not competent in the skill you actually want to test. So in other words, you want to make sure that you're not testing their ability to understand poorly constructed or hard to understand instructions. You shouldn't be testing their ability to deal with a novel situation unless that's the thing you want to test. And a student shouldn't be able to do well just through like test wiseness. If they, able to predict what the stations are going to be because it's always the same or something like that. You want to make sure that the only way a student can do well is if they really know the skill well that you want to test. So these are the things we need to keep our eye on when we set up an Ascii. So we can go to the first tip. And the first tip, they kind of start with the end in mind, is you need to decide on what the intended use of the results from your Ascii are in the first place. So it's all about what decisions are you going to make based on your Ascii. So it speaks to that first key point of the validity is the implications. So is this a formative assessment? Is it a summative? So is this assessment for learning or of learning, or where we're trying to get to the moment, is it for both? What we do in our unit is our first year students, we still give each student one practice Ascii, just so they can see what this completely novel form of assessment is like, to help inform their preparation for the Asciis that count for marks, and to sort of demystify it, because it's quite a stressful thing when you first think about Asciis. I think all of us have been a student in an Ascii and remember what it's like to try to get gloves on when you've got sweaty hands and your hands are shaking and you're trying to put it in an IV line. So the more we can do to remove those factors of the novel situation, we try to help our students do better. Obviously, the bigger, the higher stakes decisions, if it's exit level, the more focus you need to put onto your reliability and validity. One of the suggestions they give, which is actually something we do in our unit, is a two-stage Ascii, just from a managing resources point of view. Is we do one Ascii that the whole class does. It's a 12-station Ascii, and if they pass, then they're done with their Ascii. But any student that fails, we then give them a full-length Ascii, an extra 8 stations, and we use that 20-station Ascii as a way to make sure that for that high judgment about whether a student's going to fail or not is made with a bit more data. So they'll talk about a screening Ascii and then your full-length Ascii. Just because it would be really difficult. We've got more than 700 students. To do a 20-station Ascii for all 700 would be quite difficult. So once you've decided what your Ascii is for, The next thing is you need to decide is what your OSCE should assess. At the end of the day, you can't test everything that you teach, so you'll always be assessing a sample of the knowledge and the skills they've learned. So it's really key that you start right at the beginning with a really good blueprint. So what we do is right at the beginning of the year, when we're actually planning our curriculum, we blueprint our OSCE right at the beginning. So we know that our curriculum and our assessment are really well aligned. So we got to make sure that we are representing our constructs of interest adequately. So for example, you've got to decide what you want the students to develop. So we make sure on our OSCE that we've got a balance between them demonstrating the motor skills of procedures and physical examination skills, that they're demonstrating sufficient clinical reasoning, communication skills. So we want to see the patient-centeredness in their biopsychosocial approach. We want to see them interpreting investigations. So we have a wide variety of stations that reflect those outcomes. And this is really important for the generalizability. So if we've got a blueprint that we can say, if a student does well in this OSCE, I can generalize to them knowing this curriculum really well. So one of the things I always ask is how many stations is enough and how long is enough? And luckily they give a few tips for this. So they give a guidelines of about 5 to 10 minutes. Isn't it long enough for a station? A low stakes OSCE, they say 8 to 10 stations is enough. And high stakes, you need at least 14 to 18 stations. One of the really important things to keep in mind, and I think this is a mistake we make quite often, is an OSCE is a very resource-intensive way to assess students. It takes lots of time and effort. So you've got to make sure that what you assess in an OSCE is not better assessed elsewhere. So for example, you shouldn't really be using an OSCE to assess content knowledge, which could be assessed in the theory exams, or maybe even something like teamwork and professionalism is better assessed maybe in workplace-based assessments. So an OSCE should be part of a wider assessment plan that's comprehensive, and you shouldn't be using OSCE stations really to assess things that are better assessed elsewhere, because it's better to save your OSCE stations for things that are only really best tested in an OSCE. So to give an example, this is just a small part of one of our blueprints from 2020. Your blueprint doesn't have to be blue. This just matched the background, yeah. But you can see we've got lots of students in different groups. So we blueprint an OSCE for each group, but we put them side by side to see that each group has got a nice spread over the curriculum. We look to make sure that the blocks are equally represented and that the different types of stations are equally represented, so we can put together a really nice OSCE that we feel like we can generalize to the whole curriculum, and is a nice spread. So it's really good to start with a good blueprint. We have some really fun stations. You'll see one of our stations, the students do a Zulu course, and the Utini Zulu team is really brilliant and wanted to make sure that they were assessing their Zulu in a meaningful way and based on the reason the students were learning the Zulu in the first place. So it didn't make sense for the students to write a Zulu grammar exam. So actually one of our stations, the students have to perform one of their skills and then get told that the patient can only speak isiZulu. And it results in a really cool integrated station where we can see them performing their skill and applying the Zulu in the way it was intended to be used. So this is what one of our blueprints kind of looks like. This is a small part of it. We then set up another one where we show how the spread of examinations, procedures, communication skills, and special investigations are spread out. And then this can guide our assessments at the end of the year. So the next thing you need to do is develop the cases. One of the important things here is that you really want them to authentically represent the clinical problem of interest and also represent real life and best practice. So we always write our own cases and write them from personal experience because we want to make sure that they're contextually relevant, especially in the South African context. Some other things you should always ask yourself, is the task clear that the students need to perform? Is there enough time for the task? It really helps to often pilot your stations and see how you do. And is the level of difficulty appropriate? This is also a really good opportunity to show alignment within your curriculum. So we often will chat to our case application team to work in some of their cases into the things the students do so they can see that there's alignment there. And also, we align with the theory blocks. So some of the cases that they cover in their theory, they see coming up in the examinations and procedures they have to do so they can see how they're applying their theory in real life. So it's a really great opportunity to show that there's a lot of alignment within everything that the students are doing. So then the next thing you need to do is decide how your OSCE should assess candidates, and this really comes down to your scoring rubric. So what we're doing is we're trying to sort of assess observable behaviors, and you've got a couple of options here. You can have a checklist where things are either done or not done. You might want to work with rating scales where you can sort of then have a wider range of performance where something can maybe done particularly well, maybe then attempted or not done. But the biggest thing to think about is, what are you actually rewarding the students for with your rubric? So you don't want to reward students for just using a rote learning approach, and make sure that your OSCE station isn't just testing memorization, but rather you want to be able to see that the students can perform a skill with good technique, the ability to identify clinical findings. You want to show that they understand and can apply. And this is when you're going to avoid the students actually being able to get by just having memorized a whole lot of stuff without having good technique. So you've got to check the balance of your rubric is right. So it's important to avoid long checklists that reward non-specific thoroughness. We learned this the hard way. So we would have students, we had an ophthalmoscopy station where the students would use an ophthalmoscope and then they would examine a simulated patient. And while they were looking in the patient's eye and looking at the fundus, they would then give us a long list of all the things that obviously weren't there because we would have a normal simulated patient. And all the students were amazing at this. They could rattle off, dot and blot hemorrhages and hard and soft exudates and silver wiring and AV nipping and aneurysms. Then they all sounded really great. And then the 1 year we thought, we don't actually know if the students know what any of these things look like or would be able to identify them in the clinical setting. And the students were able to finish this ophthalmoscopy with a bit of time in hand. So what we did is right at the end, we then on the computer showed them a fundus, an image of a fundus where there was actually one of the pathologies, and just asked them, okay, so what is this? And it was an absolute disaster. The students had no idea. So we had obviously been making the mistake of rewarding the students for memorizing a list, and none of them actually knew what those clinical signs looked like. So that was a lesson learned for us. So now we try to avoid having the students just rattle off lots of things that aren't there and see if they can actually identify clinical findings. So make sure that the students don't get enough marks from non-essential areas that they can compensate for actually not knowing the skill that you want to test. And then if you do use rating scales, it's probably a good idea to give sort of descriptive anchors where it's not just, done well, done poorly, where you can actually, if you, for example, want to give a spectrum of performance for something like communication skills or patient-centeredness, you can give some good anchors where you can talk about, was the patient, scattered in their thoughts, was this, and give specific indications of what a 4 out of 6 means and a 3 out of 6 means, so the examiners can use those ratings a lot better. So I just want to give you an example. So I'm going to leave my PowerPoint presentation quickly. And I want to show you how we have changed our rubrics over time. So can everyone see this Word document over here? This is the respiratory examination session we gave our GEMP 1 students in 2019. I want to show you how we changed it through to 2020. So essentially the skill we want to test here is the student's ability to perform a respiratory examination and interpret the findings. So this was 2019. The students were asked to perform a respiratory examination on the patient. They then had this really complex list of instructions that they had to perform a general inspection relevant to the respiratory exam. They had to examine the hands and neck, perform a respiratory examination on the front of the chest, including the axilla, and then given a long list of things they did not need to do just purely based on how much time there was available in the station. So they did not need to perform a lymph node exam. There's a whole lot of things they didn't need to do. So it's quite a complex list of instructions that the student gets, especially trying to remember all the things they don't need to do. And then this is what the rubric looked like. So they had a normal simulated patient to examine. And what you'll notice here is under general inspection, there's a long list of things we're expecting them to rattle off that weren't there in our very normal simulated patient. When they looked at the hands, another long list of things that they needed to rattle off. On the chest examination, there was an inspection with all the things that they didn't see on our normal simulated patient. And we finally got to the bit where they actually showed us their physical examination skill. And then right at the end, they could report on the findings, which were obviously normal on the patient. And what we realized is the students memorizing these long lists was proving to be quite a large portion of the station. There are findings they knew were always going to be normal. And they were able to do that and not have great technique and still get by on the station. So then we revisited this. And this is what our new station looked like. So again, they had 5 minutes to perform a respiratory examination. The patient comes in, but the instructions are quite different. So the examiner will show you 3 images, describe the clinical signs. Then immediately we want to demonstrate the techniques that we're actually interested in the students being able to demonstrate: chest expansion, percussion, and auscultation. Report your findings. And then we're going to play them an audio clip. And they're going to have to interpret what they hear and then answer some follow-up questions. So if you look at this, they now have images. So rather than saying all the things they didn't see in the patient's mouth, they can talk about the actual sign they're seeing there. So they can talk about the central cyanosis, the tar staining on the fingers, this person's the barrel-shaped chest. And when it comes down to the rubric, that's what we're looking for, is the specific things that they were able to identify. We then now have a much more weighted part of the station that looks at the student's examination techniques, which they then do on the simulated patient. And then we play them an audio clip. So I don't know if this will play. I don't know if you're able to hear that, but we play them the audio clip and then ask them what we're able to hear, and then ask them to put all their findings together based on the pictures they saw, what they heard, what do they think is wrong, and ask them follow-up questions about what they would have expected to find on their clinical examination and why that is. So instead of just reporting normal findings, we've now created a mixture between an actual simulated patient where they can demonstrate their technique and a virtual patient where they can demonstrate that they can identify clinical findings and demonstrate some clinical reasoning. So you can see how different those stations are. And now we feel like we can extrapolate much better to what the student can do in the clinical setting based on this station than we ever could with our old stations. So that's a scoring rubric. And tip number 5 that they gave was to train your raters. So the first thing you really need to do is with your examiners is make sure that they correctly understand the scoring rubric. So it's really worth going through the rubric with your raters. Often with our OSCEs, we have to run simultaneous circuits, so it'll be different raters rating the same station, and you want some standardization there. One of the things that's really important to explain to the raters is the level of the learners and what the expectations should be, especially if they haven't been involved in teaching the learners, or if they're involved with a whole different range of students, they need to know what should be expected of these students. And one of the really important things is to give your raters very clear indications of how they should interact with their students. So it's one of the things that introduce a lot of variance, that constructor relevant variance, is if one rater is giving a lot of prompts and another rater isn't, it's going to affect the performance of the student. So it's important to be quite standardized there. So what we always say, if we want them to ask a question, we will script it in our rubric. And then we standardize the responses. So if the student is doing something they don't need to do, we tell the examiner to refer them back to the instructions. And if they continue to do something that they've awarded the marks and would like them to move on, we say that they can move on, and then we standardize instructions that they can give. And something that wasn't one of the tips in the article, but I would highly recommend, is to train the students as well. Especially give them a thorough briefing where they really know what to expect from the OSCE, to remove all that variability from the stress of the situation as much as possible, to explain how it's going to work and what's expected, to make sure that when they get down there, they can really demonstrate the skill, which is what we want to see at the end of the day. And then the last tip I want to talk about is just to develop scripts for and train your standardized patients. And standardized patients can be a hugely powerful part of the OSCE process, and I think are often underutilized. So it's really important that you do have a really rigorous and standardized approach to training your standardized patients, because it's another way variance can arrive into an OSCE. So we're very lucky that we've got a group of very experienced simulated patients that we work with in our unit. When you're writing scripts, it's not only important to make sure it's a nice, authentic case, but that it's quite rich in detail. So anticipate the questions the students may ask to prepare the simulated patient for what to do when they get unanticipated questions and what to say, because the students often come up with amazing questions that we would never have thought of. So try prepare your simulated patient for any of those possibilities. And our simulated patients are amazing at simulating physical examination findings as well. So when we're doing our neurological block, our simulated patients are great at demonstrating weakness or feigning loss of sensation. In the musculoskeletal block, they're really great at knowing when to say ow or demonstrating unusual gaits. And this picture here is one of our great simulated patients, Muzi, getting a demonstration about the neuro exam from Shannon, one of the clinical skills tutors. And that adds a really nice element to the station because the students are so used to finding normal findings. It's really great to see how they interpret when they actually get a good clinical finding. So it's a great thing to make use of. So those are the tips 1 through 6 that I think should be something interesting to talk about. I'm going to stop there. I just want to mention that tip number 8 is to choose a standard setting approach, which is what I'll be talking about in the workshop next Tuesday, standard setting, which is always a hot topic. So that will be the workshop next Tuesday. So I'm going to stop there and then stop presenting. And then I'd love to hear your thoughts. There's so many faces here I recognize that are hugely involved in doing OSCEs on a regular basis. And I'd love to hear your thoughts and experience and whether you've got any tips for anyone that wants to set up an OSCE that meaningfully assesses what we want. Are there any questions?
That is great, Stuart. Thank you very much for your presentation, and I'm sure there will be questions there. I'm glad to see if there's some in the chat to let you know, or others can raise their hand. Really appreciated the lessons learned, and I think that's something that I picked up on, and your guys realizing that there was a need to reassess and relook at the rubric, coming back to some of those tips to help with that. I know for BCMP, we've often tried to experiment, but we're also afraid to experiment. So maybe you could just talk about that for a minute. Is you're trying a new station, you want to put it out there. Do you do a beta test and not have it for marks to see how it might run, or do you put it out there and run it? Maybe later you might need to take the marks away or reweight it. Maybe just help with that, because I think all of us are trying new things now, particularly in time of COVID. And then I do see a hand coming up after that.
So yeah, I think that's a really great question. So what we do is every year we sit. I mean, it's so easy to just reuse stations again and again. We sit and try to decide if a station really worked and if it really tested what we wanted. So what we do then is we often pilot it where we actually just try it as a student to see if it works and can be done in 5 minutes. And then it's one of the ways that the formative OSCEs we do for the first years, right at the beginning of the year when they're just learning what an OSCE is like, is also a great opportunity to trial some of these things. And then because none of our stations are that high stakes, because there's a lot of stations that they do, it allows us to try new stations. And one of the really important things that I'll talk about next time is because we use standard setting, where we do not preset pass marks for the stations, there's a safety net there in case the station ends up being much harder than we expected. It allows us to adjust the pass mark so that the student's never disadvantaged by getting a much harder station. But all of our innovation has come from sitting in as examiners. So what we would see a lot with the general exam is the students would grab the patient's hands, and then their eyes would glaze over and they would stare into space. And then they would rattle off this amazing list of how there was no clubbing or koilonychia, leukonychia, splinter hemorrhages, or Janeway lesions or Osler nodes. But they weren't really looking for any of those things, and we were worried they wouldn't be able to identify them. So that was one of the big reasons we decided to start making some changes. But it's really worth trying these things out, and I think the students actually enjoy the stations more if they start to feel like they're a proper healthcare provider making, they can come to a diagnosis or conclusion or see the clinical signs. And it's really nice to use a bit of the hybrid stations where we playing noises and showing pictures and stuff like that, because I think it makes it a bit more dynamic. I think there's a hand up. Is it Ania?
Yes. Wow. Thanks for getting my name right the first time. Usually
I'm so proud.
a few times, but thank you for saying it correctly. Yeah. I was just curious when I saw this OSCE thing. because I'm actually not in the field of medicine, but actually on the humanities side with speech language pathology. And in 2019, we decided that we were going to run an OSCE as opposed to just doing oral exams where we give students case studies. So I really found your talk intriguing because now that obviously we've had to move to remote online learning, just how you presented the case. So I just want to make sure that I understood you correctly. Are you saying that some of the stations were actually face-to-face because you had to train simulated patients, and some were online? I was just trying to, if you could just give me a bit of clarity on that.
So we did all of our OSCEs face-to-face. So obviously what we used to do is we used to have those huge OSCEs where we had like 500 people on campus. So what we started doing is we had much smaller OSCEs with a much smaller part of the class. So we would do an OSCE, we would have them in all different holding venues and then only examine about 24 students at a time. So what we would do is what we still do is we book one of the big lecture theaters, then put the 24 students in there so we can spread them out over the whole big lecture theater. And that's where I brief the students and prepare them for the OSCE. And then what we do is we just make sure for each of our stations, luckily, we've got a big enough room that if it's an examiner, student, and a simulated patient, then we can follow all the COVID-19 protocols. But it's one of those things that quite early on we got permission to do because it's such an important way to make sure when the students go from us, which is sort of the pre-hospital setting, to the hospital setting, our ultimate responsibility is to make sure the patients are going to be safe. So they were happy for us to do that. One of the interesting things we did was to keep our numbers down, because we still had number restrictions on how many people we could have in the unit, is we introduced some written stations, which we never had before. Because normally you don't have written stations in an OSCE because that's something a whole lot of people can, sit in the lecture hall and write answers. So you don't always have written stations. But what we realized is that our students weren't actually developing writing skills at all because their theory questions are all multiple choice based questions. And the students were struggling. So we made sure our written stations, the only things we get the students to write are things that they actually have to document when they see patients one day. So we get them to document clinical findings or special investigation findings. And we realized it's a whole way the students weren't learning their work in a way that they could actually document findings, which is in the health sciences, if you don't write it down, it didn't happen. And we just realized they became hugely valuable stations. So now we have stations where sometimes a student walks in and they will role play with a simulated patient where they take a history from that patient, and it's all about clinical reasoning and patient-centeredness and having a nice biopsychosocial approach. We have lots of models, so sometimes the students walk in and perform a lumbar puncture on a model or an examination, and then physical examination stations where they need to show us how they can examine a knee and a foot and those sort of things. So being part of an OSCE is quite a lot of fun, and for the students, it's a weird mixture of stress and fun. And the bells ring, so it's like being on a circuit at the gym, going from one room to another. And we've seen them do really well, which is quite exciting. But I hope that answers your questions.
Yes, it does. Thank you so much.
Pleasure. I don't know who is next. I think there's a couple of hands. I think it was it Anastasia first?
Thank you so much, Stuart. I came in at the end of your presentation. I was really looking forward to today, but we're currently running the best course, and we also had to do the FOSCEs. I'm sure we've learned so much from the GEMP for the Nelson Mandela Fidel Castro program. We've had to learn from you and all that. And I see you've really moved ahead in terms of the way you set up your OSCEs. I also note your OSCEs are now with computer scripts, and I also note, like you've talked about the innovations and moving on. 3 comments. The first one is it possible that we have, just as a way of collaborating and then also growth and faculty development, that we get invited to some of your pre-OSCE planning sessions so we learn from what you're doing with the GEM program. That's one. Two, I noticed as you responded to Ania that you spoke about now incorporating reading stations, which we've always done from the get-go. Is there a particular ratio of active to reading stations that will make it higher fidelity or increase the validity? Then thirdly, in terms of improving and innovating your OSCE setup and your OSCE planning, do you kick in student evaluation at the end? I know you do have facilitator evaluations for each station at the end of your OSCEs. Do you also perhaps do a student evaluation? Maybe you spoke about this earlier on in the call, to help you improve your OSCEs. Thank you so much, Stu.
Thanks, Anastasia. I think those are all. So first of all, I think collaboration is hugely valuable. If I think how much I've learned from, I've been able to take part in IPC OSCEs as an examiner. I've been an external examiner on BCMP OSCEs, which I learned a huge amount from. I've been part of NMFC OSCEs. I think as a faculty, the more we collaborate, the better. And I would always welcome anyone to join us. I think we could also learn a huge amount from what everyone else is doing. So yes, absolutely an open invite. So the written stations, generally in the literature, they've sort of not wanted you to do written stations because if you're organizing an OSCE that's so resource intensive, theoretically a written station, you could actually sit all the students in a room and get them to write with the time limit. So I don't think there's any literature about how many written stations to have to balance an OSCE out. We just found them for our purposes to actually be hugely valuable. So written stations make up for us about a quarter of the OSCE. So it's about 1 in 4 stations that we have a written station for our GEMP 1s. Our GEMP 2s, it's less. They do about 2 written stations out of the 12 stations. So it's still not a huge proportion, but we thought it added to sort of the wideness of the scope of the skills that we were testing. And then absolutely, we get lots of student feedback. So luckily, we work quite closely with the students with a lot of small group teaching, which allows us to interact with them quite closely. But at the end of every year, I actually get, the class reps gather feedback from all the students that they send through to me. And then we learn which stations, from a student's point of view, didn't really work. It's often they don't like the stations that they feel like they can't finish in 5 minutes, that maybe the time was a bit long. And we get lots of feedback on the examiners as well. So the student feedback is very valuable, and it has been a big driver for the way our OSCEs have changed over the years. Does that answer your questions?
Yes, it does. Thank you so much, Stu. One of the things that we did with COVID was that we, with the second wave and then still having to run the exams, we increased our reading stations just to reduce, person-to-person contact. And maybe we didn't do so much research behind that, but we just found that having reading stations, like you said, that simulated what happened in real life, patients, healthcare provider contacts, helped us to deal with the COVID issue in terms of having multiple people in the same venue for almost two to 3 hours. But that's just by the side. Thank you so much.
Pleasure. Yeah, I think that's one of the things we did is when we sat down to say we needed to introduce written stations just because of the COVID numbers, as we said, we're not going to get the students to sit down and describe the, hypothalamus, pituitary, thyroid, adrenal axis. We've got to make sure that we were testing writing skills that they're going to have to do one day. So what we did a lot is we would give the students an X-ray, and just like they would have to do in the clinical setting, is then get them to document the key clinical findings, or we would do that with an ECG or like a blood gas or something. Things that, as an intern, they're going to be looking at and documenting in their notes. So it's actually an important real life skill. I don't know who was next. Was it Ame?
Yes, you can call me Maud. Yeah. Hello, can you hear me?
Yes, I can hear you.
Yes, yeah. Thank you very much for a very interesting presentation. And yeah, I also joined late at, I think you're doing tip number 5, which is, a very, very important area. Yeah, let me ask a question first that with regards to training students, Is it a matter of orientating them about the process, the OSCE process, or you also expose them to the tools that you will be using for the OSCE? Because in my experience, I still show them the tool, but then there's also a tendency of students memorizing the tool, especially that they know that we use simulated patients. And then I just wanted to share with you that with the group that, for COVID, to avoid, more contact with students rotating. So what we've been doing in nursing recently is that we use almost what we call a case-based, where a student will go in and then examine different, a system on the same patient instead of rotating. And yes, we have been using written station, but then we'd make sure that maybe it's one or two. And the written stations, we use them mainly for, like, for example, your skin problems, because it's very difficult to find patients that have got skin problems. So I've actually used written stations where I would like you to show them a picture, and then they will, have to write the findings. Training operators, it's an important aspect. And, I haven't had an opportunity to read the articles, but one of them, the title is The Hidden Labors in Designing That. Because now it means you need to have a team, of people that you'll be using in the OSCE. And from my experience, it doesn't really work to take somebody from the clinic and you meet the person in the morning, you try and orientate them, things always go wrong. So yeah, from your presentation, I've learned that the most important thing is that the raters, should be trained for, I wonder if it's applicable, the inter-rater reliability. Thank you. Yeah, so if you can tell me a little bit about how far do you go with the student orientation? And maybe just to mention that we've also, from the time when Dr. Truscott was still alive, we used to have, in the Soweto clinics, we used to have what we call TOSCI, which is basically a teaching OSCE, where at the end we would actually, go back to the patients with students, to discuss the findings with the students. Thank you.
Thank you so much. I think you raised so many very important points there. I love those written stations. I think it really keeps with that theme of, like, the dermatology stations. Is that's something that a healthcare provider really needs to be able to do, is not only identify clinical findings, but accurately document what they've seen. So I think that is a really cool written station. And I love the idea of not bringing in extra simulated patients, but getting to the students to examine different systems is a really nice way of keeping the COVID numbers down, which is really cool. With regards to the student orientation, so I communicate with the students quite a lot with regards to a blueprint for them, sort of a general blueprint of what's going to be expected from the OSCEs and each OSCE that they're going to do. We never show the students rubrics. We used to give them examples of rubrics, and what we would see is we would very much see like student robots that were all doing exactly the sort of going through the motions. And we saw very little individual flair, and the students really struggled to deal with anything that was unpredictable or ambiguous. So the moment the patient actually simulated a pathology, then they were completely derailed. So we stopped showing students rubrics because they completely lost their ability to be flexible and adaptable. So we don't show them rubrics, but I do, when I brief the students, give them a very thorough briefing about what is expected and what are the things that we value and we're looking for. So I say to the students, for example, with that station I showed, the respiratory exam station, I say beforehand, the things we're looking for is your ability to not just go through the motions, but demonstrate good technique. And what we say to our examiners is, you need to ask yourself if you feel like this student, given a real patient, would actually find the clinical findings. So I say to the students in the briefing, these are the things we value and we're looking for. We're looking for your technique. You'll be rewarded for technique. You'll be rewarded for showing good reporting, but good clinical reasoning and coming to some conclusions. So I do explain to the students for any given station what we're looking for, but our students, we never show them rubrics because we had some bad experiences with that. And then when it comes to training, I think it's our biggest factor and cause of stress is training examiners, especially when examiners are, arriving at the last minute and we've got quickly. Yeah. and Anastasia was asking about student feedback. If I get complaints, the number one complaint is when a student finds out that something different happened in a different circuit with a different examiner. So I think it's the biggest challenge. It's something we work on, is to try train the examiners. Luckily, we've got a group of examiners who've been doing it for quite a long time. Makes a huge difference. But I couldn't agree with you more. Every day, I think my biggest stress is making sure that we get our students have done tons of OSCEs, but the examiners, to make sure that they're all on the same page. So even on our small OSCEs, we're running 3 mirrored circuits. So we've got to make sure those 3 examiners are standardized. And I think it's just such an important part.
Yeah, I agree.
And then Jan, yeah, thank you very much. Did that answer your questions?
Thank you. You have.
Yes, I think again.
Sure.
I think Jan Disa had a question.
Good afternoon. That was a very insightful and informative session. I'm now working for the NMFC program, but before I was a consultant at BARA. And as you're talking about the OSCE, I keep on going back to the clinical scenario where you're examining the students in the wards, or even marking their case reports. And I realized there's a lot of variation in the way we mark students. Are you guys involved with that side of the game training, or is that a different department that does that? Because there's a lot of variation when we examine them in the wards itself. So there's people are more lenient, others are not so lenient. But yeah, are you guys involved? Maybe have a program to train the doctors who are examining the students in the hospital setting. Yeah.
So I think everyone always talks about you get hawks and doves when it comes to examination. But I think, so I'm not involved in the clinical setting. So in the clinical setting, I think all the clinical departments run OSCEs for their students. And I think the important thing is that, for example, family medicine, the final year medical students do an amazing, Dr. Ruch organizes an IPC OSCE that they do, is to train the examiners. And I think more things like this, so credit to the family medicine department for having these journal clubs and workshops, and for CHSE, which is constantly trying to help the people in the clinical setting improve their skills when it comes to assessment. I think one of the important things to do is to realize in the clinical setting, what are the best things to assess there, and what are the best things to assess with an OSCE. So an OSCE can be nice and standardized, and you can train the examiners, and you can see the students performing skills, and it's often good for patient safety that we see the students performing like that. But maybe the ward setting is a much better setting to assess things like professionalism and, assessing patient-centeredness and assessing teamwork and things like that, where we can't really see those things in an OSCE. The nature of the clinical setting is really unpredictable. So it's really hard to have a standard way that you're assessing the students and make sure that it's fair. So I think you've got to use the workplace to assess things that you can't assess in an OSCE, and an OSCE to assess as part of a wider assessment program. But I think doing things like this, and hopefully everyone here all become advocates for making sure that we assessing in a really valid way is a start. But I'm not actually involved in the clinical setting, but hopefully this will move towards that. I don't know if that answers your question, or maybe skirting around it. Aviwe?
It does, thanks.
Hi, Stuart. Hi to everyone. Thank you so much for emphasizing those important aspects for running the OSCE. So I've got a comment and a question. The comment is mostly to share with everyone that we've been incorporating some technology in some of the stations. So we leave a tablet in a written station, and we get the students to gain access to the EML. So that's been working quite nicely, because it assesses the ability to be able to gain answers and use the EML, which is going to be the bread and butter when they're working, and they're looking at management when they've got a patient or a clinical case. And then for my question, my worry is always with inter-rater reliability. So our numbers have been quite small. So we usually have like 2 circuits and we mirror it. So the stations become exactly the same. But as the numbers increase, we're probably going to have as many circuits as you have as well, which is a lot of circuits. And that means different people marking the students. So in relation to the actual station, I saw that in your blueprint, you had different stations in different circuits. I don't know if on the blue slide. Has it always been like that? What are some of the, I guess, tips or advice behind blueprinting for OSCEs? Should it be the same? Should it not be the same? Does it really matter if you're going to have different circuits? And should the aim be to assess the same thing, or what's your advice there?
So first of all, I think the tablet-based station sounds awesome, and I think I'm so glad. I think everywhere we need to move away from trying to get students to memorize things and learning students how to access data and to evaluate information. So the email station sounds really cool, and that really is an important skill when you're in the clinical setting, to be able to look things up quickly and accurately and apply that information. So I think that's awesome. So what we do in our OSCE, so when that blueprint I shared, so each of those OSCEs was an OSCE that happened on a different day for a different group of students. So one group of students, our circuits are all identical. So on a particular day, the students are all doing the same stations. One of the things, that second article about the hidden labors, one of the things they spoke about is you got to reach a point where there is some things that are sort of out of your control, that you cannot make them exactly identical, which is why you need to make sure that you have enough stations that things sort of balance out. But for each group of students, so we divide our class into 5 groups. When that group comes to do an OSCE, then they're all doing the same stations, and we try and mirror them as best we can. But you can only, they always say, you reach a point where you try to make it so reliable that you can't see the wood for the trees anymore, and that if you've got enough stations, it should eventually balance out, hopefully, all the hawks and doves. But what we do importantly is that obviously then we can't give each group the same OSCE, because if a group comes in 2 weeks' time and has the same OSCE, and then the next group has the same OSCE, they obviously, now the students have become test-wise and know what the stations are, and we're no longer accurately assessing the skills. Exactly. So each group gets different stations. And then the important thing there is that we use standard setting. So we blueprint the OSCE, so I can maybe share that screen again just quickly before we finish. The blueprint here. So if you look at, for example, Group A, they do a neuro exam, they do one of their GIT procedural skills, they take a history, and then they do a written station based on images that they get. So you'll see that the next group actually follows the same blueprint, just with a different skill. So you'll see in their second OSCE, they did one of their repro procedural skills, they had to take a history, they did one of their endocrine skills, and then one of the other procedures from the repro block. So each student has the same blueprint, but they're getting tested on different stations. Okay. And then because we use standard setting, it's there to protect. It can't just be unlucky if one of the students gets a much harder, one of the groups gets a station that's harder. If one group, has to do a lumbar puncture and another group's doing a nasogastric tube, a lumbar puncture is just, objectively harder. So our standard setting is there to make sure that no one group is disadvantaged just because their blueprint happened to involve some harder stations. So, and that leads us really nicely onto what we're doing next time, which is how you standard set an OSCE. Vera, I don't know if that answers your question.
No, you did. Thank you so much, Stuart. Thanks.
Yeah, thanks. So it's 5 o'clock. So Scott, I don't know if we must stop there. So whenever you present something like this, you don't know if you're going to get questions or not, and those are wonderful questions. So thank you so much. And thank you for listening to me. Scott, I don't know if there's anything from your side.
That has been a great presentation. Thank you, Dr. Pattinson, very much. And some really good comments and questions came through. I think you've given us far more than 12 tips, at least 24, probably doubled. And I think everyone's looking forward to your next presentation. So that will be next week. And Stuart will come back for the standard setting. And I think more about this blueprinting will come to be discussed. And then please do look further. On the 21st of September, we have our Tech Tuesday, and we'll have Dr. Krause coming to speak on that topic. So thank you, Stuart, for that. Thank you, everyone, for joining us. and a very good Tuesday afternoon and Tuesday and into the remainder of the week. Thank you, Stuart, for joining us.
Yeah, thank you very much. Thank you for having me, and have a lovely week ahead.